Hello friends, in the sequence of ENT lectures, today we are going to start in the field of rhinology, that is the science of nasal cavity and its disorder. We are going to discuss a topic named as nasal polyps, or the multiple of or the plural of the polyp is called as polypi. So let me first expand this, expand this. And so we have already uh, finished the topic of sinusitis, acute rhinosinusitis, or rather called as ABRS, that is acute bacterial rhinosinusitis. And now already we have done is epistaxis, and today we are going to start a new topic, which is nasal polyp. Nasal polyp uh, are like these are prolapsed mucosa of the nasal cavity as a result of long standing allergic response. So one thing is the most assertive about this nasal polyp is they are uh, specifically or indistinguishably associated with allergic response of the nasal cavity. So these are associated with allergic response of, or you can say they are indispensable part of the allergic process of the nasal cavity, like allergic rhinitis. So they do not, uh, uh, you can say, manifest themselves in a span of weeks, but this prolapsed mucosa of the nasal cavity happens to be over a longer period of the time, and it is strongly associated with IgE response, immunoglobulin E response. So they are benign growth. They are not supposed to be malignant growth. They are space of occupying lesion. They are S2L, but they are not malignant. They are purely benign in nature, though certain polyps are associated with malignancies of the nasal cavity and paranasal sinuses. But as such, nasal polyp is purely a benign disorder, though a space occupying lesion, or it happens to be a pathology which occupies space in the nasal cavity, but it is not a malignant tumor. It is not a malignant tumor. And the size of the polyp always depends upon the time period of the pathology, along with the you can say the intensity of the allergic response the patient is having. So they can origin both in the paranasal sinuses or in the nasal cavity. We have got uh, uh, four type of paranasal sinus, like frontal sinus, maxillary sinus, sphenoid sinus, and ethmoid sinus. So the peculiarity of this polypoidal changes is polyp is like a multiple foot, foot. So they have got uh, origin in the mucosa of the nasal cavity and is attached to the nasal cavity mucosa with multiple uh, foots, or attachments. So we have got four groups of paranasal sinuses: frontal, maxillary, sphenoid, and ethmoid. And this chronic inflammatory or allergic response of the paranasal sinuses leads to edema of the mucosa, and this persistent edema of the mucosa after some time prolapses because of huge amount of inflammatory mediators which leads to persistent edema. Apart from that, the gravitational pull of the mucosa downwards, the gravitational pull of the mucosa downwards over a period of time also leads to prolapsing of the nasal cavity mucosa, which is nothing but a nasal cavity polyp or a paranasal sinus polyp. So you can say this allergic response and this persistent inflammatory response by the presence of inflammatory mediators like thromboxane and interleukins leads to a persistent edema, which leads to gravitational pull, and this persistent edema leads to a prolapse pathology which is called as a nasal polyp. So the nasal polyp has got a multiple attachments in the nasal cavity or the nasal cavity mucosa. The most important thing about polyp is they tend to arise in the area which are more convoluted or complex and has got a hypoxic environment. So let me, nasal polyps are the abnormal lesion that originate from the nasal mucosa and paranasal sinuses. The nasal cavity is not the only source of this uh, polyp pathology, but paranasal sinus, the majority of the polyps arises from the paranasal sinuses. And it's the end result. It's the end result. And as I already discussed, the polyp happens to be after a prolonged time of the patient having these inflammatory pathology, particularly the allergic response. And they are particularly, you can say they are benign in nature, they are non-malignant, but in the sense is they do not show encroachment of the bone or they do not show signs of bone destruction. They do not bleed. They are not much vascularity they are having, and they never metastasize. So these are certain features which comprehensively suggest that the polyp are never a malignant pathology. Though you can say that there are certain tumors which are associated with polypoidal-like changes in the nasal mucosa, but as such, polyps are not associated with any kind of a malignant behavior. So you can see these are three endoscopic pictures. These are three endoscopic pictures, and this is supposed to be the unfinished process, and this is bullite moidalis. And this persistent edema of the nasal cavity over a prolonged period of time may be a result of this allergic response and a high IgE and eosinophil count, which leads to this persistent edema, which prolapses along with the gravity also to certain extent to form a polyp. This is supposed to be the polyp. This glistening white, uh, uh, which is very least, you can say, sensitive to touch, which is very less sensitive to touch, and they are poorly vascularized also, or you can say they have got a poor blood supply also. They do not have a major blood vessel in them, and the feeding vessel is usually in the caliber of a capillary. So they are also associated with sinusitis. So in fact, we can say chronic rhinosinusitis, which is also called as CRS, is of two types. Two types. One is with polyp, and the second one is without polyp. So this chronic rhinosinusitis with polyp is essentially has to be associated with IgE response, or you can say that it's a typical allergic response. Whereas the CRS without polyp is essentially a neutrophilic response, or you can say the typical presentation will be a mucopurulent discharge in a chronic rhinosinusitis, and there will be the thickening of the mucosa, and which is predominantly as a behavior of a neutrophil, just like a bacterial infection they will have. So this is supposed to be a bacterial response, bacterial infection you can say, or an inflammatory sequence you can say. Whereas with polyp is always associated with eosinophil or IgE count. So you can say in a nutshell that CRS with polyp is essentially an allergic response, or without CRS or chronic rhinosinusitis without polyp is just like a bacterial sinusitis, which is exhibited by the presence of certain bacteria like Streptococcus pneumoniae and Moraxella catarrhalis. So one important feature of this genesis of this polyp is that they happens to be in a mucosal surface which is relatively hypoxic. So in nasal cavity, we have got a complex ethmoidal complex or ethmoidal cells, which are very, very complex structure. Complex structure in the sense is they are highly convoluted and labyrinthical. They are having small cavities, which has got propensity or behavior deviation towards a hypoxic environment. And this hypoxic environment in the nasal cavity perpetuates or helps in the persistent edema, and this persistent edema leads to prolapse of the nasal mucosa, which then is called as nasal polyp. So these are two or three important points which has to be considered in a topic of polyps. The first one is they are essentially as a part of chronic rhinosinusitis with polyp kind of a pathology. And this chronic rhinosinusitis is of two types. One is as a neutrophilic response, which is a bacterial response, and the second, the chronic rhinosinusitis with polyp, is essentially is just like a patient of allergic rhinitis. This is having excessive sneezing and itching in the nasal cavity, in and bodily nasal discharge. Whereas in the case of a chronic rhinitis without polyp, they are essentially like a bacterial response, like a mucopurulent discharge, and you can see a middle meatus having a thick purulent discharge. So these are two separate classes of a chronic rhinosinusitis, and polyp are essentially present with the allergic response. So as far as classification is concerned, these are two important class of the polyp. Number one is bilateral ethmoidal polyp, when the polyp happens to arise from the ethmoidal complex, or the cribriform plate, or the ethmoidal cells. We have got two groups of ethmoidal cells, anterior and posterior, and between the two is we have got a ground lamella, is a thin part of the bone which separates the anterior ethmoidal cells from the posterior ethmoidal cells. Posterior ethmoidal cells are supposed to be large in size and pyramidal in shape, and you can easily appreciate the difference between anterior ethmoidal cells and posterior ethmoidal cells in a CT scan. And the thin plate of the bone which separates the anterior ethmoidal cells and posterior ethmoidal cell is called as ground lamella. It's called as ground lamella. And the bone which separates the ethmoidal complex from the orbital cavity is called as lamina preferentia. So the originating site of this ethmoidal polyp is the ethmoidal complex, or the ethmoidal cell, anterior and posterior ethmoidal cell. And from there, they are supposed to gravitate as a long-standing pathology. They fill the nasal cavity from upward downwards, from upside downwards, and the site of origin will be the ethmoidal complex and the mucosa over it. The second important category, this kind of a polyp, this anti-ethmoidal polyp, happens to be in IgE mediated patients or allergic patients and adult pathology. They are more prominent in adult population. Whereas this antroconal is formed by two words. The first word is antrum, that is supposed to be the maxillary antrum. What is the maxillary antrum? Maxillary antrum is maxillary sinus, or antrum of Highmore. So this polyp happens to be a origin from the walls of the maxillary sinus. Then it rotates or comes out of the middle meatus through the opening of the maxillary sinus, and then it prolapses in the nasal cavity and moves posteriorly towards the choana. What is the choana? Choana is a posterior nasal aperture which connects the nasal cavity to the nasopharynx. So let me take a structure first. So this is supposed to be the cribriform plate, and there will be the frontal sinus in the frontal bone. These are three turbinates. This is called as middle meatus, and this nasal cavity is connected to the nasopharynx. This area posterior to the nasal cavity is called as nasopharynx. So this nasopharynx. So this polyp of this antroconal polyp has got an origin from the maxillary sinus, which is in the maxillary bone, and then this prolapsed mucosa comes out of the maxillary meatus or the middle meatus and goes posteriorly and prolapses into the nasopharynx or even into the oropharynx. It can be visualized in certain patients which has got a huge antroconal polyp. It can be visualized hanging behind the uvula, and maybe mistaken as or misquerited as a adenoid, a large adenoid, or other posterior pharyngeal wall growth. So this the difference between antroconal polyp and anti-ethmoidal polyp is anti-ethmoidal polyp are essentially has got an origin from ethmoidal complex and its O-line mucosa and its adult pathology. They are multiple. Usually, they are have got the patient has got a multiple polyp, whereas this antroconal polyp has got a origin from the antrum or a maxillary antrum. Then it comes out from the maxillary opening in the which is present in the middle meatus. Then it fills the nasal cavity, goes behind towards the choana and appears into the nasopharynx. And particularly is a pediatric population or a adolescent pathology. It is present in a pediatric population or a adolescent population. So this polyp, this hanging polyp has got this surface of the polyp is nothing but a what we call as a respiratory epithelium. Respiratory epithelium is nothing but a pseudo-stratified ciliated columnar epithelium, which is a prolapsed mucosa itself, which happens to be a outcome of a long-standing inflammatory response, particularly by the presence of eosinophils. And the stroma of the nasal pharynx is edematous, and we can easily see that eosinophils are the most predominant cells in identify inflammatory cells in 90% of the polyps. So you can say that polyp has got a indispensable or insegregable association with the allergic response of the nasal cavity, the allergic response of the nasal cavity. So you can say that allergic rhinitis patient can exhibit has a tendency because they're already having eosinophilic and Ig count response. So they are the patients which are more vulnerable for the presence of the polyp. And this neutrophil is associated with the inflammatory, a bacterial kind of a response, which leads to a polypoidal changes. So it is not the chronic rhinosinusitis and the allergic rhinosinusitis are not the only pathology which leads to polypoidal changes. Polypoidal changes. So by far the most common cause of a polyp is a chronic rhinosinusitis or allergic rhinitis. Yes, but pathologies like a cystic fibrosis, which is genetic disorder, and the second one is AFS, that is called as allergic fungal sinusitis. What is allergic fungal sinusitis? It's a polypoidal response, just like a allergic response. When you have got a indoor allergen or outdoor allergen in the form of pollen grains or a dust mite, the patient may exhibit a polypoidal reaction. But this polypoidal or allergic reaction happens to be against the fungal element, the fungal mycelium. Mycelium which is present in the nasal cavity. So this polypoidal changes which are against the fungal elements present in the nasal cavity is called as AFS or allergic fungal sinusitis. They are supposed to be a benign polyp, and in a case of a pediatric population which is less than 2 years and still having a polypoidal structure present in the nasal cavity, it should be investigated for a encephalocele or a meningomyelocele or a glioma. So in a population, if a patient is the age is less than 2 years, then you should not suspect the patient for having a polyp. If you are having a polypoidal change in the nasal cavity, you should suspect for a meningomyelocele or a encephalocele, or not meningomyelocele, encephalocele or a glioma or any other congenital cerebral plate deformity, but you should not suspect a proper allergic response nasal polyp. Apart from that, another important disorder, especially in the age of greater than 2 years and less than 10 years. So between 2 and 10, if the patient is having a polypoidal structure in the nasal cavity, you should go for a sweat test, or you should suspect a cystic fibrosis. That is also involvement of the chest is there. The patient has got multiple episodes of pneumonitis or pneumonia, and breathing difficulties may be present along with sinusitis and nasal cavity or polyp. So what are the features of the clinical features of the or clinical features of the polyp? They are essentially present in the middle meatus. So this inferior turbinate, middle turbinate, superior turbinate. The area beneath this, underneath this turbinate, middle turbinate is called as middle meatus. So this area is the most important area, also called as OMC. That is called as osteomeatal complex. Osteomeatal complex. So this area is a very important area which because it has got openings of the frontal sinus, the maxillary sinus, and the anterior ethmoidal cells. And also this the inflammatory products of these three sinuses, anterior ethmoid sinus, maxillary sinus, frontal sinus, are constantly drained in this area. So the chances of polypoidal changes, hypoxic environment is frequently present in this middle meatus and the frequent site of the chronic rhinosinusitis. So if you can suspect that the most important area in the nasal cavity which is related to the generation of rhinosinusitis is middle meatus. This is the most important area. The area underneath the middle turbinate which has got opening of different sinuses, and they are insensitive to touch because of the poor supply of the nerve fibers, terminal nerve fibers, and apart from that, they have got a poor blood supply also. So the chances of bleeding from a benign polyp is rare. They rarely bleed, you can say, and the look is palish. They have got a pale whitish kind of look, and they are insensitive to the touch, which very important in differentiating uh, of a polyp from the inferior turbinate. So, in clinical examination, it's many times you can find this insensitive to the touch as an important armamentarium or armamentarium in the sense important tool in diagnosing whether you are touching a polyp or you are having a enlarged or hypertrophy of the inferior turbinate. So the blood supply is also poor. So the as far as pathophysiology is concerned, it's the chronic inflammatory, especially is the presence of the eosinophils. This is a response, and this is nothing but a prolapsed mucosa. And essentially is present with chronic sinusitis, allergic rhinitis, cystic fibrosis, and allergic fungal sinusitis. In case of this cystic fibrosis, they are usually isolated polyp which is present, but they are always benign. Uh, uh, so uh, we will go in the next. We will discuss the treatment and the surgical part, which is nothing but an endoscopic surgery. Classical surgery of the polyp has now abolished, and most of the centers are doing the endoscopic surgery, a functional endoscopic sinus surgery for the polyp surgery. We'll discuss in the next class. Please subscribe the channel also on the YouTube. Thank you for watching. Thank you.